Welcome everyone for joining. This is a Bell and Neurosom webinar, and we are focusing today on this is a progress report, investigating the role in Parkinson's disease, of investigating the role of sleep in Parkinson's disease using the sleep WISP. And we have a couple of featured speakers today. Dr. Jimenez Shawhead, Professor of Neurology and Medical Director. Uh, Movement Disorders, Neuromodulation, and Brain Circuit Therapeutics at Mount Sinai. Dr. Jimenez Shawhead will discuss the clinical importance of sleep in Parkinson's disease using the sleep WISP. In the research, the sleep WISP is a mobile EEG unit that uses AI to remotely monitor sleep stages. We have other speakers today. We have a packed agenda. So Dr. Don Tucker will review the WISP integration with AI monitored EEG guidance and the individual TES synchronization of slow wave oscillations in the research. Dr. Romer Schusterman will update on WISP engineering improvements. Our other featured speaker today is Dr. Allison C. Waters, Assistant Professor of Psychiatry and Neuroscience at the Nash Family Center for Advanced Circuit Therapeutics at the Icahn School of Medicine at Mount Sinai. Dr. Waters will address the readiness and need of a clinical trial of sleep therapy for Parkinson's disease, as well as current methodologies. Additional speakers today will be Dr. Fan Liu, will present the validation study of NEAT sleep staging software and FDA clearance for that software. And Dr. Shannon O'Neill will present on the impact of sleep issues and CBTI for Parkinson's disease. And I will go ahead and turn it over to our first speaker today as Dr. Don Tucker.
Our goal here really is a follow-up for the webinar we did a year ago in September. And we want to basically do a progress report on ways of understanding and integrating sleep WISP therapy. The essential point is that we can now improve deep sleep through synchronizing the slow oscillations that are the hallmark of deep sleep by applying external electric currents. That's the key idea. It's transcranial electrical stimulation of slow oscillations to enhance deep sleep. And this, we think, is a therapeutic approach that can be important for various sleep disorders, including in Parkinson's disease. Now, part of the classic background here is to understand the slow oscillations. And this is where the high-density EEG research has been an important part of this framework, because we were able, by using high-density EEG, to localize the slow oscillations of sleep, which are particularly strong in the limbic regions. That then allowed us to target those limbic regions in order to understand how to approach the optimal stimulation of deep sleep. So this has been part of the conceptual background. But another element that came from last year's webinar is the importance of practicality, of being able to do sleep therapy at home. And what do we need to do that? We basically need not only a headband for stimulation, and not only the AI that allows us to monitor the person's sleep automatically so we can personalize the delivery of the transcranial electrical current, but we need this in a package that people with Parkinson's disease can use it at home. So really our challenges have been not only scientific and clinical of really understanding the disorder of Parkinson's, but practical. And so part of our discussion today will be the integration of advanced engineering techniques to make it feasible to have AI at the bedside, but also to make it usable so people can deliver their own sleep therapy. And then finally, I think one of the key themes of last year's webinar was the importance of a frontline sleep therapy with cognitive behavior therapy for insomnia. So a key part of our presentation today will be recognizing the importance of CBTI and how it can be integrated into the treatment of sleep in Parkinson's disease. So with that, I'm going to turn it over to Roma Shusterman, who's going to give us an update on the engineering that we've attempted to do to make the Sleep WISP, the wireless interface sensor pod, usable in the home environment.
Thanks, Don. So to give a very brief reminder to listeners, what is our system? Our system consists of a headband, as you can see here on the bottom picture. User position the system. User has a tablet interface during the application, which shows whether the position is correct, if electrodes show a reasonable impedance. And after user is starting recording, the EEG is monitored by electronics hardware that is sitting on top of this on the head, and then it's transmitted to a WISP dog, which acquires this data and do real-time analysis for the sleep stage using neat AI algorithm, which Dr. Lu will present later. And then after detection of deep sleep and a few minutes into N2, the dog sends signal back to the headband to apply stimulation to improve deep sleep. So we have this pipeline working smoothly, and last 6-7 months, we were focusing more on improving usability. One feature on the usability that users, especially researchers and clinicians, will be able to review results immediately at the end of the night. And for this, we have a flow or data management and operational workflow system, which results of the need were sent to the flow, where user was able to observe need. Don, can you show next, please? So, and on a computer, user is able to see sleep scoring diagram overnight. And we had this even before, but what we did during last half year, we improved the synchronization, that from the moment the session is ended at morning, a session is via Wi-Fi. The session is sent to a flow, and then practically within 5 to 10 minutes after the session is over, a researcher or clinician can access this in their cabinet and review the session. Next few improvements were done to improve reliability and simplify manufacturing. So one of the major improvements we did is on the level of the headband. This picture shows the part of the headband before it's going assembled with electronics and turned into full assembly. And these are the facing to the head, and these show the positions for the electrodes. So all these snap connectors that sitting here on the headband in our first version were wired, and you can see here on the top on the right side there are two wires that are just coming outside. So all these connections were wired, and this was a tedious manual process during production to assemble these headbands. So right now we came up with a flexible printed circuit board that replacing these wires. So practically we have a printed circuit that is matching the size of this headband. And then we practically, what we're doing, we're just positioning layer of neoprene, layer of flexible printed circuit, and then layer of neoprene. We heat stake them together, and then we attach these snap connectors. So all this together reduce manufacturing time of the headband by a factor of like 80%. And also, very important, it improves the reliability of each connector. Previously, we had some level of disconnect and failures due to the wiring. Right now, with this Flex PCB, where is currently under test, but we are aiming to achieve significantly better results in terms of lifetime of the headband. Next. And then additional feature to improve users' experience, we updated communication between the WISP dock and the headband. We moved from to its native Bluetooth communication. So right now we reduced one component that it was like a USB stick was attaching to the WISP dock. And we also observed previously some level of failures or users sometimes even forgot to plug this. So right now we just eliminated this extra component to improve experience and reliability. So with this, I think we can move to Dr. Van Loo for the neat presentation.
Great.
Thanks, Roma. So as we started the project for automated sleep staging, the goal was really to make it such that we could do the closed loop neurostimulation using the WISP. So NEAT basically does the real-time sleep classification to identify certain stages of sleep, the stage that we want to initiate TES. And in this case, it's the presence of stable N2 sleep. And then we can start the slow wave stimulation to synchronize slow waves of sleep for N3. So it's basically a convolutional neural network. And as we started it, we engaged the FDA right from the start to see what their guidance or recommendations would be for development and testing, mainly for testing to show them the evidence that this thing performs, one, as good as humans, two, as good as predicate devices that have been cleared. And so one of the things right from the get-go was for us to make sure that the data that we use to train this neural network it has the properties that would allow it to generalize. And by generalization, we mean to the appropriate ages, as well as generalizable across systems, different sleep EEG systems. And so and then to separate the training data, the data that we use to train the neural network, from the data that will be used to provide a clinical validation. And so we specified those parameters and we trained the neural network. Next slide, please. Once we have that, this what this slide presents are the data or the characteristics of the data we use for the validation, totally separate from what we use to train. And so there are two data sets from two different systems. And then you can see the various or the age range of the subjects that went into or that make up the data, and then the actual segments of EEG. So you see the different stages of sleep and how many segments of EEG data were contained for each stage of sleep across the two data sets. And then what we do is have each data file scored by three independent sleep centers and scored by sleep technologists, certified sleep EEG technologists. And we get three ratings for each data file and each segment. And then we compute an agreement. So whenever a segment is scored the same by two of the three scores, then we establish the identity of that segment, the sleep stage of that segment, as the gold standard. And then we run NEAT through that, and we calculate the positive agreement, a negative agreement, and overall agreement, both for NEAT as well as a predicate, as well as against human raters. And we can use the same criteria for human raters. When two agree, then we see if the third one we fix the first two raters, and then the third rater, how often they agree with these two raters for a given segment according to the gold standard. Then we can change that around for the other raters. Next slide, please. And so here we're just showing the positive agreement, PA, negative agreement, and overall agreement. And this is against the gold standard. And so looking in the column of NEAT overall agreement, you could see that the range of the percent agreement is quite high, ranging from 84 into the mid 90s. So essentially, all it's saying is that compared to the gold standard, the overall agreement for NEAT is quite high. And actually, if we look at these numbers, it's more or less comparable to the highest agreement rate of humans. So it's performing as well as humans on sleep staging. It also, when compared to predicate, the predicate device, it performs comparably. And this, the results form the basis of what the FDA used to evaluate whether it performs as expected. And so based on that, that's how we were able to get to FDA clearance for NEAT. The one thing about NEAT, again, I want to emphasize, is that it can do it offline. It can perform sleep staging offline, but it is quick enough such that we're able to use it in real time for the closed loop TES neuromodulation. Thank you.
Great. Dr.
All
O'Neill.
right. Yes, thank you. Hi, everyone. So my name is Dr. Shannon O'Neill. I am a certified CBTI specialist, which is an evidence-based protocol offered for those struggling with sleep-related concerns. So this could be not only difficulty starting to fall asleep or initiating sleep at the beginning of the night, but also frequent awakenings in the middle of the night, after sleep onset, and premature awakenings at the end of the night. All right, next slide, please. So this is a relevant protocol within my work because I offer behavioral medicine interventions to those managing various neurological conditions. And as for Parkinson's, disordered sleep is one of the most prevalent non-motor symptoms. Approximately 90% of patients report nocturnal sleep disruption. And of those, insomnia affects 80% of those with Parkinson's. Many patients I work with will endorse difficulty falling asleep, awakenings after sleep onset, which then leads to this fragmented or inefficient sleep, as well as just this poor sleep quality. And this nocturnal sleep disruption can often lead to napping or dozing during the day, worsening cognition, as well as poor motor functioning, which is another area of their concern. You can go to the next slide. The National Sleep Foundation, as well as the NIH, recognize CBTI as the first line of treatment for those battling insomnia. This is always very exciting and something I share with absolutely every patient because psychotherapy typically never gets first line of treatment. There's always a stronger medicine or device out there. So it really shows how significant this protocol is. And I also want to emphasize the protocol is more than just sleep hygiene. People think that if they put their phone down at night before they go to bed, that they're doing CBTI, but that's not the case. A few hallmark interventions that I typically offer individuals with Parkinson's, these things that are discussed in session together, typically a consistent wake time, even if I'm not working with someone on sleep-related concerns, I always emphasize the foundation of just starting your day at the same time every day, regardless of the sleep you received the night before. So a set wake time, this allows for the circadian rhythm to be set, a sleep drive to begin building across the day, which promotes that sleepiness that you crave at night. And it can also assist with just organization or structure of the day as a whole. So for individuals with Parkinson's, the consistency and timing of their medication across the day. I also encourage patients to resist sedentary behavior throughout the day. And this is a very big feature of CBTI. So for Parkinson's patients, they may be going into long-term disability or navigating retirement. And there's less structure, which often leads to daytime fatigue, deconditioning. They might nap or doze. So I encourage patients to keep moving and have a schedule across their day just to serve as an anchor. And then lastly, many sleep guidelines often suggest a scheduled bedtime, but I really refrain against that because that puts too much pressure on someone who might not be ready for sleep at a certain time every single night. So I suggest to individuals, specifically with Parkinson's, wait until you feel sleepy or drowsy before entering bed, which leads to compressing that sleep window in order to fall asleep and stay asleep more efficiently. These are just 3 guidelines with so many more that CBTI recommends, but just giving you a little appetizer of what CBTI entails. Okay, you can go to the next slide. All right, one more back, I believe. Nope, I'm sorry. Go to the next, there we go. Okay, so the literature first examining CBTI for Parkinson's has shown it to be successful in reducing nocturnal total sleep time, increasing or sleep efficiency, and improving subjective sleep quality. However, there are some limitations to CBTI for this demographic specifically. The most significant is the limited accessibility to providers. I did a quick Google search, and I believe this was in a New York Times article in the past few years. The number of CBTI providers that are out there that are certified is in the 600 ballpark in the US. And the number of therapists or even just psychologists, PhD level psychologists as a whole is reaching 200K. So it's a very niche treatment and specialty. So there's a lot of obstacles to be able to gain access to this technique. The reliance on self-report data collection is also very difficult. Data is prone to be very biased from the patient's subjective reporting that they're doing. It's very old school pen and paper. And the preoccupation with perfecting one's sleep quality, which ironically can just result in hyperarousal and worsen the symptoms, more clock watching, perfecting the data on their tracking. The traditional pen to paper tracking can be frustrating for people with Parkinson's because of the fine motor skills that are involved. And then lastly, the range of pathologies to be diagnosed can't be captured with the subjective tracking and needing for more objective information. Okay, last slide, please. So in an effort to offer more accessibility to specialty care such as CBTI, as well as regulating the safe use of AI, our team developed a study to assess how a chatbot can implement these services. However, to assist in regulating the content that was delivered through the chatbot, the study was organized in two separate ways. So first, we limited AI's knowledge to a very trusted domain-specific source, such as a CBTI manual. And we also established a two-agent system of a therapist first generating the first drafted answer of a CBTI intervention, and then a supervisor checking the answer against trusted sources, such as that CBTI manual. And so what was tested, the CBTI experts, including myself and Dr. Waters, we blindly compared AI answers with human therapist answers. And the findings suggested that AI's answers were often rated equal, if not better, than human responses, mostly because they were more elaborate and detailed. But humans sounded warmer and more personal. So the takeaway from this, the study suggested that supervision and also trusted sources, AI chatbots could safely support treatment with CBTI, ultimately improving access to care, of course. However, it has yet to address the tedious data collection and the subjectivity offered by patients' personal tracking systems. And hopefully, I think this is a bridge to Dr. Waters. I'll hand it off to you.
Thank you. Yeah, it was Dr. O'Neill, it was Shannon's insights that working directly with patients with Parkinson's disease that really opened a new avenue of research at the center. What we discovered is that when we sit and we talk with people who are living and thriving with Parkinson's disease, they tell us it's not the tremor, it's the fog, it's the memory lapses, concentration, it's exhaustion that starts the moment they wake up. So poor sleep in Parkinson's disease isn't a side story. It's really central. And we also know from population studies, we may hear more about this from Ju He, that losing even a small fraction of deep sleep, of N3 sleep, dramatically increases the risk of dementia. And in Parkinson's disease, we know that the very systems that regulate sleep are themselves disrupted by the disease process. So that creates a kind of vicious circle. They're getting less sleep. There's a buildup of toxic proteins like alpha-synuclein and a faster decline in cognition. Around and around we go. So what are we doing about it? Let's move to the next slide. At Mount Sinai, we're running a trial. We're testing the sleep WISP in patients with Parkinson's disease. Our trial includes daily sleep diaries, that old school pen and paper, surveys about mood and subjective sleep quality, but also actigraphy and phone-based neurocognitive testing to assess our primary outcomes. And let's take a look at some of them on the next slide. Really important here, this was our first go, no go. Early outcome is that the device seems to be working as designed. So here we have a hypnogram that we would have received from Bell simply by logging onto the flow interface. And we see, I've marked in green, that the stim was triggered at exactly the moment that we expected it to be, and then it was followed by an epoch of deep sleep. This is not trivial in Parkinson's disease, because the staging algorithms are designed on healthy brains, and we don't know if it'll hold for PD. So in a sense, this trial is not just about developing the therapy, it's also validating, maybe even rebuilding with the collaboration of our industry partners here, these algorithms for this specific population. All right, let's move on to some primary outcomes from the study. So for this individual, you can see their percent N3 increased over the study week. That's what we're going for. And the stack plot below is comparing the nights with stimulation on to the nights without stimulation. And gosh, we can see maybe, I think, a 7% decrease in wakefulness throughout the night, a little bit more REM, a little bit more N3 with stim. But what's really interesting in this particular patient is their delayed recall score the next day after stimulation. That's our measure of memory consolidation. And it jumped about 20 points on stim after stim on nights. So, wow. This is not a statistical effect. These are pilot numbers, but this is clinically very, very promising. Tells us we're going in the right direction, keeps us motivated. On that, the next slide, we need to keep our patients motivated as well. So actually a big part of our trial is feasibility. Here we're looking at some comfort ratings, how they steadily improved over the course of the week. These are the patient's ratings of the comfort of the device. And you see their ratings of how easy the application was, went from frustrating to 5 out of 5 over the course of the week with some practice. Another really important point is that on nights when they got stimulation, they didn't report disrupted sleep. If anything, we see from their diaries that they were reporting that they were awake a little bit less that night. I don't know if that's, statistically relevant, but the point is that the stim wasn't waking them up. This is the usability piece. It's so essential because we can't make progress here at Sinai without our patients, who are really our collaborators in this context, able to use the device and wanting to use the device, to continue using the device. One of my trainees, Mason DeLigi, did his graduate research on this work. So we've got a manuscript forthcoming that is discussing some of these results and also what excites us the most, which is really where this is leading. Maybe we'll move to the next slide. It's beyond just neuromodulation alone. I think that's where Shannon and I are really united. If we can begin to closely integrate behavioral sleep health, the essential components of CBTI with at-home EEG and tracking, we're going to reinforce the lasting benefits of both types of therapy. So we can imagine pairing this with an AI-driven coaching or extending this to other diseases of aging, mild cognitive impairment, mood disorders, beyond. All right, our real essential question here for this trial is whether we can treat sleep in Parkinson's disease not as a symptom, but as a potential lever to change its course, okay? That's the bet that we're making over here at Sinai, and our motivation for collaborating with our industry partners. Because if we're right, we might not just be able to help people feel more rested, we might actually slow the disease progression. So that is our mission, and I hope you'll all join us in supporting that goal.
Great. Thanks, Dr. Waters.
Yeah, you bet. It's nice to be back. Thank you for being so responsive to our requests after the last pilot. I hope you saw our patients responded.
Well, that's the point, is that we, in our last webinar, we found a number of problems and limitations, and that's been our goal over the year to make improvements with those. So let's see, do we have our last speaker, Dr. Jimenez Shahed, joined us yet?
Yeah, thank you for having me on this webinar as well. So
Right.
I guess my job here is to kind of bring it home and explain the significance of this problem that we're dealing with in helping our patients and managing our patients with Parkinson's disease. And then to convince you that Mount Sinai is going to be an excellent partner for Bell and for the NeuroSom project. So I'm Juhi Jimenez Shahed. I'm a movement disorders neurologist. I am the medical director of our neuromodulation and brain circuitry program for movement disorders at the Bonnie and Tom Strauss Movement Disorder Center of Mount Sinai. And we're located at Mount Sinai West, which I'll sort of show you on a map of Manhattan towards the end. Can I have the next slide, please? So as I think was mentioned, sleep is a huge problem in patients with Parkinson's. And as I'll show you, it sort of even predates the onset of motor symptoms that might lead to its actual diagnosis. I can give you just an anecdote because I was just in clinic this morning, and this last patient that I saw, I swear this isn't just a convenient story to tell, but her primary complaint today is her sleepiness. And she is just, she's fine. She's taking her levodopa. Her Parkinsonian symptoms are fairly well controlled with the medications. And we have just been struggling with this issue of her daytime somnolence. And it's a tricky one, I'll say, in some individuals. But I think it highlights the fact that we need better treatments to address this problem of sleep disruption and sleep dysfunction in Parkinson's disease, because we can do a pretty good job of controlling the motor symptoms, but this particular non-motor one, it's so multifactorial that we have a lot of information that we have to dig through to try to understand what the root cause is and then to implement appropriate therapies. So having new approaches is certainly going to be helpful for a number of different reasons. So without trying to recapitulate some of the information that you already heard from the other presenters, I just want to highlight how significant sleep disruption is and sleep problems are in Parkinson's. Insomnia remains one of the biggest complaints. It can be either in the form of sleep initiation or sleep maintenance difficulties. I really consider this to be a multifactorial problem because then once you figure out that the issue is falling asleep or staying asleep, you have to figure out, is that because the patient has uncontrolled Parkinson's motor symptoms at night that leads to reduced mobility? Is it because they have other non-motor symptoms that are interfering with sleep, such as depression, which can come with significant sleep disruption? Or do they have nocturia, where they're getting up in the middle of the night to go to the bathroom and then having trouble falling back asleep? So these disruptions can also contribute. Could it be the Parkinson's medicines that they're taking? There are certainly medicines that can make people sleepy, and then there are medicines that can keep people awake, and we end up having to try to balance that and to time the medications appropriately. The image at the bottom here depicts the altered melatonin rhythms that are well known in Parkinson's disease patients. I just love this graph because it's so clear. The top part of it is normal, healthy controls, and then at the bottom is the melatonin secretion throughout the night of patients with Parkinson's disease. So very clearly disrupted, right? I mean, very different. And that leads to and contributes to the sleep pathology. And there's also a number of other sleep co-pathologies that can exist in patients with Parkinson's. So whether that's restless leg syndrome, whether it's sleep apnea, whether it's REM behavior disorder, there's all these different potential contributors, and we have to clinically at least try to distinguish and target our therapies appropriately. Go to the next slide, please. Excessive daytime sleepiness is one of these. And just as in the patient that I was mentioning to you just now, again, we have to go through these sort of algorithm of trying to understand the contributors to the excessive daytime sleepiness. Is it the medications that commonly can cause sedation? Is it sleep medicines that we've given them for the nighttime sleep problems that are now then causing problems during the day? Is it their non-motor symptomatology, as I mentioned before, like the depression? Or again, is it the co-pathologies? Is it the insomnia? Is it the restless legs, the sleep apnea? apnea, the REM behavior disorder. Again, I spend a lot of time managing Parkinson's motor symptoms, but then probably after that, the number one and number two are things like constipation and sleep issues. So these are very, very common manifestations. Next slide, please. REM behavior disorder is probably one of the most well-known sleep disruptions that occurs in Parkinson's disease. And this is characterized by vivid dreams and dream reenactment that can take the form of things like talking, yelling, screaming in sleep, or punching, kicking, or hitting. There may be different manifestations in female patients versus male patients. On polysomnography, it's characterized by REM sleep without atonia. And this, of course, is problematic because it can pose risk to the patient in terms of self-injury, but then also to the bed partner if they're the target of this dream reenactment behavior. And as I was mentioning before, this particular sleep pathology is a common non-motor precursor to synucleinopathies. And a young person who presents with isolated REM behavior disorder has upwards of a 95% chance of developing an alpha synucleinopathy later in life. And this is well established through multiple cohorts. So this type of disruption is highly recognized to be associated. And again, frequently occurs and requires management. The picture on the right here shows the Brack staging hypothesis of neurodegeneration in Parkinson's disease, and it really kind of highlights why some of this can be prodromal to Parkinson's disease, because the initial pathologic changes and degenerative changes that occur are within the brainstem and within those areas that house our sleep structures and our sleep circuitry. And so this is often something that patients start dealing with before the Parkinson's and then continue to deal with throughout the disease course. And I'll show you some more information on that as well. Next slide, please. Restless leg syndrome, I won't go through the diagnostic criteria, which is on the left there, but this is another sleep disruptor in Parkinson's. We know that the incidence of RLS seems to be higher in Parkinson's population. It may precede the Parkinson's motor symptoms. It may begin after the Parkinson's developed, and it certainly may be aggravated by a number of Parkinson's factors, such as the medications, the wearing off of the effect of those medications, or maybe even the excessive movements that occur from the medication, such as dyskinesia. And there's a lot to sort of sort through there in terms of how that impacts sleep, but probably what the primary manifestations are. But the impacts on sleep are undoubtedly, problematic when they occur. These patients tend to have a great deal of sleep initiation difficulty, and then if they happen to wake up for some other reason, and I've already mentioned to you several of the reasons that they might, then they may have symptoms manifesting again, which can further disrupt sleep. So it's just an endless cycle for some of these individuals. Next slide, please. Obstructive sleep apnea is a common occurrence just in the general population. In Parkinson's disease, it seems to be higher. There are wide-ranging estimates of its actual prevalence in Parkinson's disease, and there may be a number of different reasons for the wide range there. But there has been recent evidence that has suggested that a history of obstructive sleep apnea increases the risk of Parkinson's disease, and the corollary to that is that treatment of the sleep apnea actually reduces the risk of Parkinson's disease. So certainly another factor to consider. There may be several contributing factors to either the development of sleep apnea or to the impacts that sleep apnea may have on patients with Parkinson's disease, including the hypoxemia, the sleep fragmentations, the inevitable alterations in lymphatic system homeostasis, inflammation, etc. All of these are well known to be associated with the phenomenology of sleep apnea. And again, these patients get into this really difficult cycle of impaired sleep leading to excessive daytime sleepiness. And then there's other sort of consequences of that. Allison, you mentioned cognitive disturbance, which I wasn't planning on getting into here, but that is, another sort of major, after effect of the sleep disruption. But you can see how this impaired sleep, daytime sleepiness sort of, going back and forth, we're chasing our tails a little bit in terms of chicken and egg, and we just need to find effective interventions for these individuals. Next slide, please. And this is just a summary slide to show you that, as I mentioned earlier, that sleep disorders are prevalent, they're common, and they worsen as Parkinson's disease progresses. This was, I think, a study of over 200 patients with Parkinson's disease followed longitudinally for 5 years. And you can see that on the left-hand side here with the circles, that there were 55% of patients with no sleep disorders at baseline, but by 5 years in, there were only 30% of patients who had no sleep disorder. The most common ones being the REM behavior, the excessive daytime sleepiness, and the insomnia that we discussed. But I think the other thing that I want to draw your attention to here is the overlap. So these patients have multiple sleep pathologies. It's not just one. Or it would not be, it's fairly common to have multiple, I should say. And then on the right-hand side, this graph here just shows over time the prevalence and the reporting of each of these different features, the insomnia, the REM behavioral disorder, the excessive daytime sleepiness as time progresses. And you can clearly see that some of these things are increasing in prevalence as the disease progresses. So certainly another aspect of Parkinson's disease that we have to continue to monitor and to manage for our patients. Next slide. All right, this is just kind of tying this all together. So there's a number of reasons that people can have these circadian alterations in Parkinson's disease. There's this concept of chronodegeneration now in neurodegenerative diseases, where there's a range of circadian alterations that can occur. I talked to you a little bit about the melatonin changes that occur in Parkinson's. These patients may also have higher cortisol levels. There's alterations in clock gene expression. And all of these have significant influence on not only the development of Parkinson's disease, but also its progression. And the polysomnograms here on the right that are showing the sleep stages, the top one here in row A is a normal, healthy control patient. So you can see that this patient has, the stages progressing through into the deeper stages of sleep. The next 3 are patients with Parkinson's disease, and you can see very clearly that these deeper stage 3, stage 4 sleep epochs are much less. And then not only that, what you're also seeing here is disruptions during the day related to medications as well. So again, highlighting just all the different features of sleep dysfunction that we see in patients. Next slide. So with that, then hopefully I've convinced you it's a significant enough problem and it makes sense to study this device in the Parkinson's population. Just to bring it home to Mount Sinai a little bit, go ahead and go to the next slide. We're very experienced at the Bonnie and Tom Strauss Movement Disorder Center in terms of conducting clinical trials in Parkinson's disease. We're a Parkinson's Foundation Center of Excellence. We're a site and investigator members of the Parkinson Study Group, which is the largest not-for-profit consortium of clinical trial investigators. I myself am actually the co-chair of that organization, so we're very tightly linked towards within the clinical research community. We're also a clinical site for the Michael J. Fox Foundation Parkinson's Progression Markers Initiative. Some of you may be familiar with that if you are already in the Parkinson's disease research space. We have 3 clinical sites that are seeing movement disorders patients with 10 primary movement disorders faculty from whose clinics we can recruit subjects. These clinics are supported by nurse practitioners and several research coordinators. Our faculty additionally includes a sleep specialist, a sleep psychologist who you've met, a psychiatrist, and we have a robust clinical trials history and pipeline across all Parkinson's disease stages, and also across a variety of treatments, whether that's observational studies, genetic and biomarker studies, pharmacologic studies, device studies, and surgical studies. Next slide, please. This is the last slide that I have actually, is just, these are our clinical trialists. So that's Manhattan there. On the Upper East Side, we've got Dr. Winona C., who runs clinical trials out of the main Mount Sinai Hospital. Matt Swan is down at our Mount Sinai Union Square location and runs clinical trials there. And I head our clinical trials activity on the West Side. So we've got a large population to recruit from, and we're really eager to be able to recruit patients for the study of this sleep device. So thank you for your attention.
Great. Just want to thank all of the presenters today for such excellent presentations. And I want to open it up now to the Q&A portion of our webinar. We do have a first question. This is for Dr. Waters. This is about the pilot study that you did with the sleep WISP. Do you know what major aspects of the application were the most frustrating to the participants? I think this is about when you were talking about the device and some of the initial frustration that people had with it.
Yeah. I think they would say impedance checking And what we discovered was actually that we hadn't trained them right. So we had them we had trained them to the point of perfect impedance. So they were working and working and working to have one electrode that could have been a little higher impedance, very, very low before they went to sleep. So working with impedance was one of them. Another, I would say, was just nerves about getting it right. So the driving the scores down at the beginning of the trial would be people reporting, or the patient reporting, that they were unsure whether they were going to be able to do it in the evening the way we wanted them to do it. So they were worrying about it over the course of the day. But then they learned, they got used to it. That's a great question. That is the question we ask as well.
Right. Yeah, just getting people used to using the device and probably getting experience brought people's confidence up with it, I assume.
Yeah. And we're learning how to teach.
Absolutely. I just encourage anyone else that has questions to go ahead and put it into the Q&A section. If anyone else has questions for any of the speakers that we have today.
I'll go. Can you guys hear me okay?
Yes.
Awesome. Thanks all for fantastic presentations today. Julie, maybe you would be the best person to answer this as a clinical perspective. How do you kind of envision, I mean, both you and Allison kind of touched upon this, but it would be nice to perhaps summarize, how do you see improving sleep translating into better clinical outcomes for Parkinson's patients?
Yeah, no, that's sort of the crux of the question, right? We want our patients to do better. We want them to have better outcomes in the long term. You know, Parkinson's is a relentless, progressive neurodegenerative condition, right? So any aspect that we can offer to help with the various pathologies and contributors to whatever it is that they're feeling. And I think, Allison, you sort of alluded to this, or maybe it was Shannon, that, you know, if you're not sleeping well at night, you're going to feel pretty yicky during the day. So it's not only just how you feel, which clearly will affect your quality of life. It's also how you function. So people will then have secondary additional sort of neuropsychiatric consequences potentially of not sleeping, whether that's mood issues, anxiety issues, cognitive issues, et cetera. And, you know, this is progressive. Right. So I think there's like a reason that sleep deprivation is a torture tactic. It really works. It makes people really function very poorly. And so the best, you know, whatever we can do to sort of improve this particular aspect is a source of huge frustration for patients. Right. I mean, they already have so many medications that they're taking throughout the day. If we try to tell them, here's another medication that you can take, you know, that just adds to their burden. I think patients are very interested in finding non-pharmacologic approaches to the problems that they're experiencing. I think there's a lot of increasing literature and awareness about brain health and how sleep contributes, or poor sleep contributes to poor brain health, and how therefore addressing it helps. So patients are themselves paying a lot of attention to this. So I think that, you know, this is likely to help on multiple fronts. And I think if there are really tangible benefits that patients experience from their use of a device like this, or any intervention really to improve their sleep, they're going to want to stick with it, because it is, you know, it really has the potential to be very impactful in a number of different ways, both in the short term and the long term, I should say.
Excellent. And so taking maybe a fast forward to a few more years, right? How do you see integrating something like a sleep WISP, or even more wearable devices? I think Allison alluded to in one of the slides as well. How do you see some of that as clinical trials show benefit, right, for this patient population? How do you see that being integrated into the patient care?
Viral, can I address that question by way of addressing your first question as well? Another domain is early diagnosis and early intervention. So in some ways, it's useful for us to place patients in their own category, as if they're different from healthy aging, but actually they're great teachers. And in some ways, we can think of PD as a form of accelerated aging. So if we could make some kind of device like this accessible to all middle agents out there who are interested in having better sleep quality, that what we might see happening is that some early stage addressing of sleep problems actually slows the disease progression. I don't know how preventative it will be, but that's definitely a goal. So how would we integrate it into care? Actually, one point that I'd like to make is that even just having access to the sleep data from the bedside is a really significant move forward, because here at our center, we would have to send a patient out for a full polysum workup at a sleep clinic in order to get sleep information. So before we're even talking about treatment and neuromod, just sending the device home and then having access to their sleep data the next day is really a critical contribution to care.
And I'll just add to that I think wearables, we're in a very, interesting and exciting stage of wearables these days. They've got multiple uses, multiple applications. There's the part where you can measure things more objectively and better. And so that enables our clinical trials. It enables our ability to, identify objectively outcomes or positive outcomes, maybe negative outcomes, but also positive outcomes of clinical trials, and with more granularity than subjective rating scales. I think, this is kind of an area that Allison sort of specializes in, which is the ability to provide feedback to patients. And they really sort of, I think, thrive on this. They like to see the data. They like to see the numbers. They like to see, also taking it a step further, the impacts of the interventions maybe that they have. So I think there's a sense of agency here that, it gives to patients, a sense of engagement with their therapy, and the fact that they're doing more for themselves and they can see the actual results of those interventions. So I think that we have the opportunity to do multiple things actually with this particular device. It kind of covers a lot of those different fronts.
And then from a research perspective, just as a research tool, the questions we can ask are so exquisite. We can't wait. I mean, Shannon and I have been wanting to work on multi-arm CBTI plus neuromod plus biofeedback integration to understand these very interesting interplays between subjective and objective measures of sleep as people are overcoming their sleep anxieties and making needed changes to their sleep habits. I think we could help and make some progress in multiple domains just using these tools as tools of research.
We have a few more questions in the chat, and this one kind of piggybacks on, I think, what you've been talking about. If the sleep issue is due to neurodegeneration in the brain, then does the sleep treatment still work? It's one of the questions.
That is such a super important consideration. And I think, Allison, you probably alluded to this in your talk as well. Maybe we need to adapt the way that we're delivering this because of the degenerative process. It might be different than or accelerated in some way compared to what healthy controls who have sleep disruption might experience. So I think that's kind of a work in progress. I think to date, we can intervene in managing symptoms, and that's independent of the neurodegeneration. I mean, I think at certain point with Parkinson's disease, there become symptoms that are really difficult to treat with medications. Somehow I either have the experience or the feeling that we can always intervene better on sleep, and that's not necessarily, the ability to do that isn't necessarily 100% restricted by the neurodegenerative process.
So step one was, could we even trigger the device with this fragmented sleep? It's looking good, but it's going to be essential for us to have partners, Dr. Liu, to work with if it comes to pass that we need to be developing PD-specific algorithms for sleep staging. Let's see if that's needed. But also we're targeting deep sleep right now, and maybe that's not the right target. Or what we might discover is that it isn't the deep sleep per se that's leading to the health benefits, but we're perhaps augmenting REM sleep drive. So what we end up doing is addressing the REM sleep disorder that we didn't even expect that to be our mechanism of efficacy, but there is that potential too. The only way to know is to run the trials.
Right. That makes a lot of sense. Next question is on a specific measurement aspects of the headband. Do you know if you are able to measure any autonomic function measures as well as the sleep stages?
I'll address that. We don't currently with our metrics. However, and our measurement is the EEG. But we know that a couple of the channels we have, particularly across the mastoid or to the neck, get big cardiology signals. We get big ECG because the heart propagates up through the neck. And if we get around the neck, we get that big ECG signal. And the ECG is a good measure of autonomic function. And we can see it change, and it's just because it's such a huge signal change in REM. So REM sleep often has these pulsatile, really extreme exaggerations of sympathetic nervous system function. And so those could be measured with the REM, with the headband, and cross-correlated against the REM EEG staging. So it's a very interesting and important direction. The other thing I'll point out is that Allison was emphasizing the importance of multiple wearables for the data points that we want to get. Simple watch measures like the Apple Watch or other techniques give good measures of cardiac function, of heart rate. And so even from those alone, we can get a lot on an everyday basis, and that could supplement what we get from the WISP measurement. So I think this era of wearables gives us a very important kind of data that will supplement what we see from self-report.
And this question, I think, is kind of talking about those Parkinson's trials as well. Do you know if there are any current clinical trials looking at the quality of sleep in response to other interventions? For example, exercise interventions.
Yeah, I think there are. So either as secondary measures or just sort of exploratory, et cetera, for a number of different primary interventions, whether it's pharmacologic interventions or not. I think another sort of area of interest where we've seen a lot of stuff recently is in light therapy. And there's a few companies out there actively doing clinical trials of light therapy for not only probably predominantly non-motor symptomatology in Parkinson's disease, but then also, again, looking secondarily at motor benefit and other cognitive, et cetera, types of outcomes. So it's definitely an area of interest, but still one lacking dedicated therapies. We still don't have, that therapy that is specific for Parkinson's disease sleep disruption.
Great. Well, I think that are all.
Yeah, one more question from Muthu. Let me go and ask that. Don, you would probably be the best person to address this. The question from Muthu here is, are we looking for the N3 epoch before stimulating? If yes, for those patients who have initially very less N3 epochs, would this be a problem?
Yeah, no, that's a good question. And it kind of fits about the specificity of Parkinson's sleep that we deal with. And so with healthy individuals, even including seniors, we found a technique that we don't have to wait for their N3, because the loss of N3, the loss of this deep stage of slow oscillations in sleep, occurs with normal aging. The N3 declines across the lifespan. so that treating an older person is problematic because their N3 is decreased. And if we had to trigger on it, then we would be in trouble because they may not have it for a long time. So what we did originally, we decided we would wait to a certain amount of N2 until they're statistically likely to go into N3, even if they haven't. So that's what we do. We measure 4 minutes of N2 sleep. And that's typical for the first interval of the night for most people. And then we just turn on the stimulation. So we're not reacting to the N3, we're proactively stimulating it. And it turns out, just, practically, for the great majority of people, their N3 gets synchronized. They start having N3 as soon as we turn on those slow oscillatory stimulation. So the brain can't tell. The brain just slavishly synchronizes up with these external currents. And it makes it actually fairly easy to manipulate the brain during sleep because it is responsive to those external currents. So this is not to say that there won't be problems in treating Parkinson's. I think it's an open question. This is why even the limited pilot data at Sinai is giving us some confidence that we can treat these patients. But as has been said over and over again, we need the evidence. We need to do the work to find out, can we successfully improve their sleep the way we have with healthy controls. So with healthy controls, we've just replicated the fact that the WISP sleep therapy not only enhances the target deep sleep of N3, it also enhances REM as a subsequent side effect. So in healthy controls, we know about it. Parkinson's, we don't know and have to find out.
Great. Well, I think that's all the questions, and we're a little bit over time. I think we could go here all day. We've had so many great speakers, fascinating talks from everyone. Thank you so much to everyone today, and thank you to everyone who joined. Really appreciate it.